If we now look at the posterior axioappendicular muscles, we can split these into two groups, a superficial and a deep group. Here we can see on this side of the screen the two superficial muscles I want to talk about, trapezius and latissimus dorsi. We can see trapezius here has both a superior or a descending part. We have trapezius here forming a transverse or a horizontal part, and we have trapezius here forming an ascending or a more inferior portion. Three parts of trapezius: a superior, we call it a middle, and an inferior portion of trapezius. We see it's running from the midline, from the spinous processes of the vertebrae, and also from a structure called the nuchal ligament that's coming from the occipital bone. We can see it's passing towards the spine of the scapula, as we'll see. If we move over, we can see another superficial muscle, and this is latissimus dorsi, a large flat muscle that again is coming from the spinous processes of the vertebrae, both thoracic and lumbar vertebrae, and also this white membrane here, which is the thoracolumbar fascia. And this muscle passes up towards the intertubercular sulcus. It also attaches to the intertubercular sulcus of the humerus. We can see it passing up in this direction. So these are the superficial muscles. We can see we've got a descending, transverse, an ascending part of trapezius, or a superior, middle, inferior part, and here we can see their specific origins. The nuchal line and external occipital protuberance for the descending part, the nuchal ligament for the transverse part, and the spinous processes of these vertebrae here. And we can see that the external occipital protuberance, the nuchal ligament, and the spinous processes. And they're passing towards the spine of the clavicle, attaching to the lateral third of the clavicle and the spine of the scapula. So these are attaching to this region. The nerve supply is quite unique. It's coming from a cranial nerve. The spinal accessory nerve is cranial nerve number 11. So damage to the cranial nerve 11, the accessory nerve, gives an inability to elevate the scapula. It also receives innervation from spinal nerve C3 and C4, and this is thought mostly to be for proprioception, which is that positional sense. So these nerves carry information about the level of contraction within the muscle, tendon, and the Golgi organ of the muscle, allowing the central nervous system to know how much that muscle has contracted and therefore where it is in space. The function of these parts of trapezius, so the descending part helps to elevate the scapula, the transverse part helps to retract, pull the scapula backwards, and the ascending part helps to depress the scapula. So important movements of the scapula. Working together, the descending and ascending parts help to rotate the scapula superiorly. Latissimus dorsi, we can see it's coming from those bony regions that I mentioned, and it's passing to the intertubercular groove, specifically the floor. It's innervated by the thoracodorsal nerve, and this originates from spinal cord segments C6 and C7. It's important in extending, adducting, and medially rotating the shoulder joint. So latissimus dorsi is important in extending, adducting, and medially rotating the shoulder joint. If we then look to the deeper muscles, we can see we've got two rhomboid muscles, minor and major, and levator scapulae. And we just go back to the previous slide to see these. Here we can see rhomboid muscles running from the spinous processes of the cervical and thoracic vertebra, and they pass towards the medial border of the scapula. We can see we've got two parts to the rhomboid muscles. We have rhomboid minor, which lies most superiorly, and we have rhomboid major, which lies inferiorly. And sometimes you can make out a separation of these muscles, but in most cadavers, the separation is actually quite difficult to see. But you have rhomboid minor and rhomboid major. Here we can see passing upwards towards the skull, we have levator scapulae. And that's important in helping to, as its name suggests, levate elevate the scapula. So we can see rhomboid minor and rhomboid major. We have the minor coming from the nuchal ligament and really the spinous processes of those vertebrae, and major coming from inferiorly, so coming from spinous processes of the thoracic vertebra inferior to C7 to T1, coming from T2 to T5. But really this runs as one block of muscle. The minor one inserts to the superior aspect of the medial border, and the major one inserts into the inferior aspect of the medial border of the scapula. Both of these muscles are supplied by the dorsal scapular nerve coming from C5, and it's important in being able to retract the scapula, so pull the scapula backwards, and also rotate it inferiorly. So rotate the scapula inferiorly, which serves to depress the glenoid cavity. Levator scapulae is running from the transverse processes of C1 to C4. That's where it's coming from, and it runs down to the superior angle of the scapula, so that when this muscle contracts, we can see its origin here. When it contracts, this distance is going to be shorter. This is going to stay where it is. It's going to remain stable, which results in the scapula moving upwards. So we're elevating the scapula. It runs to the superior angle of the scapula, and it's innervated via the dorsal scapular nerve, which comes from the fifth cervical spinal cord segment. It elevates the scapula and is also involved in rotating the scapula inferiorly, again depressing the glenoid cavity. So these muscles can work together in that sense.